Perfect. So thank you for being here. We're gonna, for the sake of time, so we have some time at the end for questions. We're gonna present our speaker, Dr. Golami, from the Division of UC Davis Medical Center in Surgical Oncology. She's gonna clear our minds about using intraarterial chemotherapy for metastatic liver cancer. Okay. So thank you, Dr. Golami.
Well, thank you everyone for still being here on a Saturday afternoon. I hope to really go through this talk, but also leave a good time for the end to really have a discussion and just make it informal so that we can really learn from each other. So it's a great honor to be here to present on HII therapy for primary and metastatic liver cancers. Here are my disclosures. For this agenda for today, what I'm planning to do is give you a brief background and rationale for using HII therapy for intrahepatic cholangiocarcinoma as well as colorectal liver metastases. Then the majority of the talk will be broken up into two sections where I go over the efficacy data for colorectal liver mets and then some for intrahepatic cholangio. And then I'm hope to end it with showing you some results from two recent surveys that were done through the Research Network and the HII Consortium that were presented last at the SSO meeting as well as at this meeting. And I'll leave you with some future directions and then open it to discussion for the audience. So what's the rationale for using liver-directed therapy for colorectal liver metastases and intrahepatic cholangiocarcinoma? Most of you have heard really over the last several days over and over that control of liver disease has been really shown to increase survival for both colorectal liver metastases as well as intrahepatic cholangiocarcinoma. And we also know from the literature that the majority of the recurrences recur within the liver. Now, the tumor derives the blood supply from the hepatic arterial system for both of these malignancies. And this is the reason why we can exploit really this tool and use HAI therapy, which increases the tumoral and intratumoral concentration of chemotherapy and really limits the systemic side effects of typical systemic chemotherapy that we see. And we also know that FUDR is a 5-FU analog, which has been shown to have clinical efficacy against colorectal as well as intrahepatic cholangiocarcinoma, which I hope to show you in the next section. So what is the efficacy data? Let's start off with colorectal liver metastases. Now this goes way back to the early 2000s. Most of this work has obviously been really pioneered by Dr. Kemeny and the Memorial Group, so that you'll see a lot of the same authors over and over again, which has really been the major criticism of the data here, despite it being mostly positive. So let's start off with really focusing on unresectable disease for colorectal liver metastases. This was one of the first trials here addressing this question, looking at 135 patients with unresectable disease. The intervention was HAI with using FUDR and leucovorin and dexamethasone, and the systemic group received 5-FU and leucovorin only. When you look to the right, you can see that the time to hepatic progression was significantly longer in the hepatic artery infusion group. And then below that, the Kaplan-Meier shows the median overall survival was longer in the HAI group compared to the systemic therapy group with 24 versus 20 months. Now, what about the conversion to resection rates in those who were unresectable to begin with? This was a phase 2 study led by Dr. D'Angelica and the Memorial Group. You can see that the intervention included now HAI FUDR, but also now included systemic therapy with oxaliplatin and irinotecan, as well as 5-FU. Those are the three different options of systemic that was really at the discretion of the clinical provider. The majority of these patients were on second and third line therapy, so pretty heavily pretreated. And if you look to the right, you see that the conversion rates were about 50% at a median time of treatment for 6 months. Looking at the survival curves, you also see that those who were untreated and treatment naive had a significantly longer survival compared to those who were pretreated. But again, in all comers, it showed an increased survival when you compared it to the systemic groups from the historic literature. Now, the next question then became, what about adjuvant therapy? And I'll go sort of in some sequential studies here. Initially, it started off with a randomized trial that included, again, 156 patients who underwent complete hepatic resection. The adjuvant therapy then in the intervention group included HAI with FUDR plus 5-FU leucovorin versus the control group only got the systemic with 5-FU and leucovorin. Again, if you look at the hepatic-free survival as well as the median overall survival, it was a significant bigger difference between the groups who had HAI systemic therapy versus the systemic therapy group alone. So again, a positive study. But I think here you can also see at a median follow-up at 10 years. So this was the updated publication here after 10 years. Those survival curves were still separated, and the survival was increased in the HAI plus systemic chemotherapy group versus the systemic alone. Now, again, the criticism for all of these studies that I've shown you so far is that this is 5FU based. We now have modern chemotherapy, and that those results really don't hold true if you look at currently what we have available for these patients. Now, this is exactly the question that Dr. Kokenam with the Memorial Group during his fellowship was trying to answer. So this was actually published in the JCO. It included all those comers that had resection at Memorial Sloan Kettering. And then these patients were then basically looked at two different groups, one that had systemic therapy alone versus those who had systemic plus HAI chemotherapy. They then performed a propensity score analysis and really based on the matched chemotherapeutic based on modern and sort of the prior era of systemic therapy. The overall survival curves, again shown to the right, show a significant increase in the survival in the HAI plus systemic group versus those who underwent systemic alone. But really the focus was this section. What about those in terms of looking at modern chemotherapy versus non-modern chemotherapy? And if you look at the preoperative modern chemotherapy group, those who received, had including like modern therapy, still had an increase in their survival in the systemic plus systemic plus HAI group compared to the systemic only. Also, if you look under the adjuvant therapy, very similar results were to be found here. The patients who had HAI plus systemic outperformed those who had systemic alone. When I was at Memorial as a fellow, there was this really hype about biomarkers and sort of like molecular markers for colorectal cancer, and there was discussion about primary tumor location and RAS status. So then I asked myself, well, should we really putting in pumps in patients who have maybe a RAS mutation? So we answered this question by looking at all those patients who had available RAS status at Memorial Sloan Kettering. That's included 674 patients. This was broken down into those who were mutant or not, with 418 versus 256 patients. And we had a median follow-up of 6.5 years. The tumor characteristics that I don't have the table here to show you just with looking at the space, but I can tell you that with regards to all those factors that were predictors that we've known with regards to synchronous disease, the number of metastases, clinical risk score, as well as two-stage hepatectomy, all of those were actually in favor of the systemic-only group. So again, we had worse disease and predictors in the HII group. Now, looking at the survival curve, there's two things I want to highlight. First of all, we found out that patients who had RAS mutations were doing worse compared to those that did not, which was not a surprise. But specifically, if you then look on those patients who were RAS wild type, for example, so those are outlined with black. I don't know if this works. Does it actually work? Ooh. I don't think it actually has a. So look at those with the RAS wild types who did not have HII therapy are shown in black. So if you look at the red and the black curve, those who were wild type and had HII therapy did significantly better than those who did not. And then also, if you look at the mutants, a very similar pattern is seen. If you were a mutant and you had HII therapy plus systemic, you did better than those who were a mutant and did not therapy. So it really helped both of those groups. And I think one sort of observation that I personally had looking at this data is that if you look at the blue and the black line, you can potentially say that if you are a mutant but received HII therapy, maybe the effect of HII can sort of mitigate the negative effects of the RAS status that we usually see as a negative predictor. What about primary tumor location? So we, again, looked at a very similar conceptual question of, does primary tumor location really impact HII therapy in those who undergo resection followed by HII therapy? So for this, we used the same database and came up with patients from 1993 to 2012. Of those patients that we actually knew the primary tumor location specifically with the PATH report, Patients with rectal cancer were then excluded. Patients with multiple primaries were excluded, as well as BRAF mutations, as well as those we did not know the known RAS status. And so we ended up basically with 487 patients. Those were then broken down into left and right-sided tumors, and then we then further stratified and looked at those who underwent HAI therapy plus or minus systemic alone. Here are the survival curves again. Very similar findings with regards to the RAS status. And so we know that left-sided tumors do better compared to right-sided tumors. So here that similar finding is there. But again, within those who have left-sided, you can see that left-sided plus pump therapy does better than left-sided without. And then similar results on the right-sided. Right-sided plus pump does better than right-sided minus pump. So, and then we ran a specific analysis and interaction and did not see actually any specific interaction on pump helping one group further more versus the other. So it seemed like pump therapy worked on everybody. So we basically said that both the RAS status as well as the primary tumor location cannot really be used, to either select patients for or not for the pump. So that's what we learned from that. Now let me review a little bit of the intrahepatic cholangiocarcinoma data. This is some of the stuff that I presented on Wednesday for the cholangio session. But again, all the work is pretty much from Memorial Sloan Kettering. So this included, I'm getting tired of saying Memorial Sloan Kettering, but unresectable intrahepatic cholangiocarcinoma. They started to look at basically patients who underwent pump therapy plus systemic versus systemic alone. 236 patients were included in those patients who were unresectable. When you excluded the distal cholangiocarcinoma in metastatic patients, the distant metastatic patients, they ended up with 167 patients that were in total treated. Those were, then they broke out further into those who had pump plus systemic versus pump systemic alone. 8 of those underwent resections. And if you look, those are actually equally distributed between the pump versus the systemic group. But the waterfall plots on the bottom here showed some really exciting results, that the partial response rates were significantly higher in those who had pump therapy by almost 20% versus those who had systemic therapy only. And then in those who had liver-only disease, the patients with pump therapy plus systemic really, again, outperformed those who had systemic alone, with a median overall survival of 30 months versus 18 months. So again, 30 months, I mean, these numbers were really significantly higher, so that what we've seen was systemic therapy alone for patients with intrahepatic cholangiocarcinoma historically. This naturally then led to a phase 2 study as a single center that was done with systemic therapy, gemcitabine and oxaliplatin plus pump therapy. The primary outcome for this clinical trial was the PFS of 80% at 6 months. And if you look down to the waterfall plot, you can see that 60% of those patients had a partial radiologic response. 11% were converted to resection. And then the study was positive and it met its primary endpoint. The progression-free survival was 11 months, and the overall survival, again, was a median of 25 months. Again, much higher than what we knew from historic data. Obviously, this was a single arm study. But now this has led, excitingly, to this new center-funded, NIH-funded randomized controlled trial that is going to be using GemOx plus or minus pump therapy. This is led by Dr. Sursex and Dr. Jarnig at Memorial, with the other centers mentioned below. And I think besides the actual randomized clinical trial, to finally answer this question, what is even more so exciting to me is really looking at AIM-2 and 3, where we really have like a significant body of like correlative studies, including cell-free DNA, radiomics, and looking at genetics alterations to really hopefully come up with like a better predictor and risk stratification model in terms of understanding who are those patients that we really know that will actually respond to therapy. Because as we know, selection is always key for these kind of treatments. Now I would say that obviously everything that I've so far presented to you, and it becomes pretty obvious, is that it all comes from a single center, it all comes from Memorial. That's been the major skepticism, which is a fair argument. But I can tell you that over the last several years, there's been a really large number of growing pump programs across, not just in the United States, but also in Mexico as well as in Europe. And that's really led to sort of this new consortium that we've built. And within that, we've really seen that it's not, we have started now looking at different publications that have come out over the last 2-3 years. and really showed that the efficacy as well as the safety data are pretty comparable when you have been, but performed by a group that is experienced and also like trained. I think that's been key. So it's really not just a treatment that works on the Upper East Side. So you can here now look at these two publications. To the left is a recent publication from the Duke group, 21 patients, single center. When you look at the safety, the feasibility, and the efficacy data, these are very similar to those that were reported by the Memorial group. To the right then, you have another recent publication by the Canadian group. This was a multi-centered, so 6 centers, 54 patients, and looking again at it, the safety, the complications rate were about 14%, feasibility was 96% from those initiated, and the efficacy data was also very similar with a disease control rate of 82%. So I think we can actually see that, it is not just something that works there, but I think it really requires a really trained team, and obviously the Memorial experience goes really far with those results. So I think this slide really speaks louder than some words I can use, but it can tell you that now we have over 50 centers that are actually, in the progress of doing a pump program or have already initiated a pump program. So it's been a really exciting year to see this HII Consortium Research Network come together and really now ask the right question at the right time. Because I do think that the skepticism is there for a reason, and that this is now really the best time to answer finally these questions that we have been really needing to answer with multi-centered randomized controlled trials. So we've been meeting over the last year and a half. This group is led by Dr. Litsky and Dr. D'Angelica, and it's been really a great experience. So I can tell you that one of the first questions that I personally had, and I'm going over several years of challenges on trying to build a pump program, was when I started talking to sort of other colleagues and co-fellows, was like, what were your challenges? And we went back and forth, and we realized that really nobody has ever published about how do you really put a pump program together. So this is a poster that we just presented today. We really basically created a survey using SurveyMonkey and asked some really key questions on to those, and the survey was basically sent to all the providers that are part of the consortium. We had 28 surgeons that responded to the survey. Was about an 80% response rate. This was not, now there are 50 programs. So back then, this was almost like a year and a half old, so we did not have 50 programs back then. And I can specifically show you that when it becomes apparent, so over the last 5 years, about the majority of these programs have really started over the last 5 years, with over 60% of those. And when you look at the necessary subspecialties that we asked in a ranked order form from most important to least important, surgical oncology and medical oncology was obviously the high runners, and then really followed very closely by nursing, nuclear medicine, pharmacy, as well as interventional radiology. Obstacles and challenges. I can tell you that most of us that have started programs, it has been challenging, and I think the answers make a lot of sense when you specifically look at sort of the timing of the survey and the pandemic. So regulatory, I think that is not a pandemic thing necessarily, but having access to equipment. We know that the Codman pump, basically went out of business for about 2 years, and now it's back as Entera. But in the meantime, we all struggled with being able to place those pumps and had to temporarily use the Medtronic pump as a replacement. Drug access, I think, during the pandemic was also difficult. There was some serious FUDR shortage at most of the centers that have experienced that. And then financial and medical oncology support. I think some of these were actually pandemic related when we had further details in the comments. Now, the last survey that we just recently presented at the SSO meeting was, I was curious of really looking at details of what are the practice patterns of what these new centers are all doing. Are we actually doing everything that Memorial is doing, or who is doing what? And so we put, again, all of our minds together and came up with a survey asking these questions. The survey this time utilized 28 questions and went on to med-oncs as well as a surgical oncologist. We had a 78% response rate. And again, here the centers shown that partaken in the survey, that was just not just in the US, but the countries that are not shown as Mexico, as well as our friends and colleagues in Oslo, as well as in Amsterdam. And so looking at specifically, we asked, what were your intended indications when you started the program? Like, what did you, initially just try to open the program for in terms of offering patients the HII therapy? everybody agreed that it was for unresectable colorectal liver mets, followed by unresectable intrahepatic cholangio, and then further down was adjuvant therapy for colorectal liver metastases, and some for early recurrences with less than 12 years. Now, when we then asked, what are your currents, so between the time that you opened your program and currently, what have been sort of the changes, we saw that, again, unresectable colorectal liver mets is still sort of the top riser, but now you see that more clinicians are actually using it for adjuvant colorectal liver metastases compared to unresectable intrahepatic cholangiocarcinoma. So that was some finding that we thought was actually interesting, and to some surprise of us, because we didn't really think that there are so many people that actually are buying into using even pump in the adjuvant setting. So then we looked at specifically factors that the clinicians were using for using HAI therapy and selecting patients. For colorectal liver mets to the left, you see that extrahepatic disease was the first comer, followed by, what was your response rates to chemotherapy on systemic, followed by portal lymph nodes, then the background liver disease. And if you look to the intrahepatic cholangiocarcinoma, very similar pattern, except for now the background liver disease makes sense. In intrahepatic cholangio becomes a little bit more of a selection factor for those clinicians compared to colorectal liver metastases. So I think in conclusion with both of these results through the consortium, we've shown that among those centers in the research network, practice patterns were actually relatively uniform. Most providers really preferred earlier referral for evaluation. As programs really gained experiences and the indications really expanded now to include adjuvant therapy for colorectal liver metastases. And I think really the research network and consortium really is an ideal environment to really study these questions prospectively with randomized controlled trials. Which leads me to the next randomized controlled trial that is basically going through the collaborative group as well as obviously the ECOG-ACRIN group. So this actually has gone through the colon cancer task force. I actually sit on that committee, and I can tell you that at the NCI this was actually seen pretty favorably. So I think it has a good chance to actually get through the GI steering committee. This study is led by Dr. D'Angelica and Dr. Litsky. So I just wanted to take a moment to show you what the design of the clinical trial is that we've been working on over the last really like year or so. So it really is a trial for patients who are unresectable disease. It's a phase 3 study. To the left, you'll see the patient's resectability and the patient selection criteria. Prior systemic therapy, essentially you've had to be on your first line therapy within only 6 to 12 months of any providers. It could be 5FU based, so we included actually everything, including even FOLFOXIRI. And then also we included patients that could potentially have up to 5 small pulmonary metastases. The randomization will then be, FUDR, HAI FUDR plus doublet chemotherapy. That again will be up to the discretion of the provider compared to just the institutional standard of systemic therapy alone. Importantly, there will be stratification for RAS status as well as left-sidedness that I've shown you why, and EGFR and monoclonal antibody will also be allowed for those who are RAS wild type, of course. So I think it will be really interesting to see really what this study will show. The primary endpoint is right now, it's basically set for overall survival, and secondary endpoints are listed below. Pretty much this typical things I would expected with PFS, progression-free, so hepatic progression-free survival, conversion to resection, as well as toxicity. And then there's a number of correlatives, including cell-free DNA, that we're looking into and hopefully learn to hope more from. So with that, I hope I've shown you really that HAI therapy is an effective treatment for well-selected patients, for patients with colorectal cancer as well as intrahepatic cholangiocarcinoma. The implementation of new programs is safe, it's feasible, and it is effective. However, it is absolutely important to have training, expertise, and a multidisciplinary team. And I think the research network really presents a great opportunity for large-scale randomized trials so that we really can ask the questions that we've been wanting to answer for a long, long time about HAI therapy. And with that, thank you very much for this honor, and I'll take any questions.
Thanks a lot, Dr. Golami. I think you took all your time, and for the sake of time and to keep on with the meeting. Unless there's a very brief question, if you want to make it, go ahead, and just to respect the people that is next to us.
Great work, Sep. I really like how you nicely presented that, both for adjuvant, colorectal, and the whole spectrum. I think a big question that will come up is how, for patients with unresectable ICC, what liver-directed therapy will we end up ultimately using? You know, we'll have the results of the circuit trial pretty soon for Y90 with GEM-CIS report to see if there's a benefit there. Do you see a trial upcoming for HAI systemic versus whatever comes out of CIRCA?
I think that's a great question. I would say yes if, you know, the next trial would actually be positive. I think we would have to wait for both of those results to come, because as you know, with most trials, sort of, you know, even design, what you really need is, like, you don't want to start now designing something that's going to be really already out of. So if I think we have to wait. I think going too fast now with designing multiple trials that may actually fail. So once we have, I think, the circuit, and we have our own data from, you know, like obviously the Memorial plus that multi-centered, I think then we will have at least a knowledge of like what should be the backbone of both of those. But I think you do need a head-to-head comparison in order to really answer that question. It was very clear from the Wednesday session that there is not enough data out there, right? So this is a pretty data-free zone. So, you know, whether it's transplant or you use Y90 or you use pump, I think we're just really cross-comparing, and which we're not supposed to do when it comes to trials. So I think the jury is still out, but yeah, that question should be answered for sure.
Well, thanks a lot, Dr. Golami. I bet she will answer any question I would like to ask more questions to her, but let's respect the time for the others. Okay, thanks a lot, Dr. Golami.